I didn't realise it was serious at all, to be honest. I just thought, well, this is something I've got, I'll get over it, you know, that's how it'll be. I walked to the ambulance and just turned around and said goodbye, see you later. And my wife, who has a different story, is saying, she started to freak out, that might be the last time I see him. Where that never even entered my head at that time. Coming out of the ambulance into a wheelchair, being wheeled into a room, put onto a bed, and just told, you know, we're going to give you a little injection to relax you. That's the last I knew of reality for the next 2 weeks.
In intensive care, we're very used to dealing with critical illness. It's what we do for a living, and we've seen many respiratory things like swine flu, for example, seasonal flu, pneumonias. This is something different, and we're all taken a bit aback by just how ill this made people. Surviving critical illness is all about marginal gains, so what you want to do is each little bit, you want to do it really, really well.
Our intensive care senior nursing team, in response to the pandemic, worked through very quickly how they were going to cope with this overwhelming demand for patients, and they ran a phenomenal programme, refreshing skills for people like me who'd been out of ITU for some time. They developed a team approach, so it felt less stressful. That actually the really experienced intensive care nurses were going to lead a team, and that we were going to work through the needs of the patients for that day, and we were going to work as a team to look after a group of patients rather than the traditional one-to-one.
What we did that I think was very effective from the start is that we limited the number of hours that nurses or staff stay inside the COVID bay, and in doing that it allowed them to think more clearly, because the wearing of the PPEs can be quite not just physically taxing, but it can also be psychologically too stressful. The two teams, the first team will go in from between 8 till 10, so that's a 2-hour rota, and then the second team will go in from 10 till 12. And in between that, the teams will have to prepare their tasks before they go inside the base. And I have to always tell myself that these protocols are in place to keep me safe and to keep my other fellow colleagues safe as well. So I think doing that 2-hour on, 2-hour off, it allowed nurses to go in and give their best and make sure that there's a continuous presence of care for that individual patient.
The team leader would organise the structure, and then they would design their teams as to what bays those team members would be working in. We had to move away from the traditional one-to-one nursing, so one critical care nurse per one critically ill patient. We literally maintained the team structure as much as possible.
Each shift will have a unit coordinator, and we will have 2 teams. Team 1 and Team 2, and within the teams there will be a nurse 1 who have IT training to concentrate more on the critical care based nursing with regards to cardiovascular support, the renal support, the ventilation support. So it helps you focus more on that aspect. While the nurse 2, who are often sometimes from the wards, what they concentrate more on are the tasks like nursing care, mouth care, eye care, and skin care, which are equally as important, obviously. So in doing that, what we did is we maximized the talents of all the nurses that we had on shift.
I went in on the Sunday evening, and then on the Monday, obviously around about 6 a.m, the liaison team called my wife and said that I'd gone quite serious, so they'd taken me to ICU. At about 4 p.m. on that Monday, they got another call just as my daughter came through the door and said, we're going to have to put him on the ventilator. So that's when they knew it was critical. If the patient is thought to be just about to die, they will invite one person in. And that happened to my wife. But my daughter recommended, remember your husband, how he was in the good times. Don't see him with all the tubes and ventilators in.
It was really clear that what was needed at the very beginning was very clear guidance for people to use, because we were conscious that we were going to have a whole load of staff that were coming to work with us, redeployed staff or people that have been out of ITU for quite a while, that whilst they had the skills may not have had the recent background in critical care. So having a very clearly defined role to follow was really important. So that was definitely key. And it relieved a lot of stress and anxiety that those staff had about returning to the workplace, because they knew that they were being looked after, and that was really important.
We have to be quite prescriptive in the way we go inside and the way that we do the task, mainly because it allows all the care that we have been doing for one-to-one nursing to be accomplished somehow, because obviously it won't be as personalized as one-to-one nursing care, but with the team's approach and that type of care of 2 hours in, 2 hours out with nurse 1 and nurse 2, it allowed us to be sure that all the vital nursing care are provided for the patient. We have what we call the task board inside each bay, so you have the time as to what you need to do at this time, and we tick the boxes as to what has been done. Say, mouth care has been done, the patient has been rolled, this medication has been given for this hour.
I suffered, I'll really say suffered, a reality for me of hallucinations. Not being able to move, being constantly thirsty in those hallucinations was so horrific. But I think being under like that really draws out the negative side and the insecurities that come up from there, and it's frightening because you are laid bare psychologically, I think, in those 2 weeks.
One of the real advantages of the team nursing is not just that you rotate people through with PPE and limit their amount of time in the COVID area. That was the original reason it was set up. But there's the 2 hours that they're not in the COVID area as well. And I don't think early on we appreciated how important that time was. Because what it meant was that you had staff who were together, who had opportunity almost to self-debrief in a way. Moral distress is recognised as a problem within these environments, and it's something we are very aware of, and we were aware that this situation was exacerbating that. And I think it was about recognising that early on and making sure that there were mechanisms by which staff could just talk about how hard they were finding it. And in truth, I think the reason why staff absence is as it was, and which is quite low, and morale is quite high, is a sum of all the parts. I think it is about debriefing. I think it is about making sure that our staff are not spending undue amounts of time at any one time in PPE. It is about making sure that they've got time outside of the COVID area to talk and to rest. And I think it's all of those things which have contributed to that.
Actually, when I woke up, I remember this nurse looking at me with a face shield and all the PPE, saying, "Hello, Ken," or asking me my name, what I thought the date was, where I was. That was my first waking moment, and I think that was about 20 hours after I was actually taken off the ventilator and taken off sedation.
The success of caring for somebody doesn't only depend on one person or one unit. You have the whole trust supporting you, and it's not just critical care on its own, but the whole trust supporting you.
The level of teamwork and collaboration that went on across the board, in particular our own units, and that with other units, is hugely positive and encouraging in that this should go on. It would, I think, enable better collaboration and integration between the critical care areas in particular. There was very good utilisation of the skills sets that were out there that couldn't actually perform in their normal roles.
There's been a necessity for us to have conversations with people within the trust that we wouldn't normally have spoken with, related to deployment of staff, to physical environment, to the use of PPE. And it's required us to speak with members of the executive team about how we do those things and how they can open doors for that. So that's been really something that is still an ongoing feature of what we're doing, actually, because we've still got a lot of work to be done.
As soon as they were able to, I got a care package of photographs and messages laminated so they could clean it. So my daughter was very aware of, I don't know if it's getting around the system, but getting something to me to help me remember and reconnect with the family, because she's obviously aware that can happen. So just getting messages of how much I meant, how much they, I'm gonna cry now. It just meant so much.
We recognised in the early stages that there was a need to address how we deal with relatives and how we deal with the patients in order to sort of bridge that gap. In order that the nurses and the medics on ICU could actually stay looking after their patient and stay focused and not worrying about how to support the families, which is quite a large role.
It protects the nurses from a lot of emotional harm and hurt, that they feel so close, and they've worked, you know, in difficult conditions with PPE and sweat and all of the normal ablutions they have to deal with, which that gets me as well, that they deal with that in PPE is they need as much help and support as they can get. Those calls obviously have been great. They were looked forward to. I think in the first week they were twice a day, morning and evening, and then as I was probably turning the corner in terms of looking as though I was going to survive, it was once a day, but they were a lifeline for my wife.
We decided that we would phone the relatives every single day, and it gave comfort to the relatives that they knew that they were getting a way of information about their relatives as to how things were going and progressing.
So we've got a number of family liaison teams across the organisation, and with the aids of technology, as the patients get better, we look to ensure that we could communicate with patients' families to keep them up to date at this really, really difficult time.
Nationally, the recovery, by recovery I mean survival from a critical care for coronavirus, nationally is not quite, but it's about 50%. Locally, it's about 80%. So it is a big effect, and the hospital and everyone involved in this should be immensely proud.
I know that you have worked. I'm going to start crying again because it means so much. You've worked tirelessly for somebody you didn't know to save their life, and I'm eternally grateful. You've avoided a nightmare in our family. I wasn't the only one there, but you cared for me as if I was. And you were going through hell as well, and just thank you. It's, I don't know you by name. I might remember some, but the doctors explained, were gentle, the nurses were caring. That I just remember the care, the professionalism that I had, but just thank you so much.
The model of care that the critical care team has implemented has been very effective, and I think it can be a good template for further pandemic planning.
Frequently hearing we mustn't go back to how we were before COVID, whether that's at ward level, departmental, cross-divisional, trust, system level. There's so much learning of what we can do when barriers are removed, and we re-put the patient at the focus of this. So there's just a newfound respect and pride for each other, for the trust and for the NHS that the country's found. The overwhelming response from the community, from charities, it's been phenomenal. So there's so many positive things that have come from this.